Hi everyone, I'm Clark with CK Med, and this episode is powered by Med School Tutors, your resource for one-on-one online tutoring for the USMLEs, shelf exam, and even the residency application process. Our tutoring incorporates custom study schedules, content mastery, and even test-taking strategies that you're not really going to get anywhere else. And I know this because I used to be a student with MST before I even tutored here. For a free phone consult, use the link in the description below. Mention that you heard about MST from CK Med on YouTube, and use this discount code CKMedPlus for your special pricing. I hope you enjoy the video.
Hello everyone, and welcome to CK Med. My name is Clark. I'll be taking you through urogenital and sexually transmitted infections tonight. I want to shout out to Nikki Shaw for creating the backbones of this PowerPoint, and I've added in information very important for your Step 1 exam. So to begin things off, before we actually talk about the infections, it's important to know what are the risk factors to getting urinary tract infection. And so the first one, in pregnancy, it makes sense that the change in the anatomy will make you a little bit more prone to having infections. Diabetes as well increases your risk of all sorts of infections, but one of them being UTIs. Urethral length, higher incidence, obviously, in females because they have a shorter urethra, and so those bacteria and everything only have to travel a very short distance in order to get into the bladder, and then they can have their way around. Obstruction or decreased clearance, like a stone formation or something like a tumor in the bladder or the prostate or something like that in men. Anything that leads to obstruction can increase risk of reflux, or anything that can increase risk of bacteria making their way into the urinary system. Catheterization obviously makes sense. We're taking a long kind of rubber tube thing and shoving it in through your urethra. Obviously, it's going to take everything with it. So that's why our sterile technique in the United States hopefully is preventing this from occurring. However, it still does happen. Frequent or recent intercourse obviously increases risk of that as well, kind of pushing bacteria in retrograde into the bladder and everything like that through the urethra. And obviously, again, this is going to be more common in women. Antibiotics as well, anything that kind of decreases the natural flora of anything such as urethra or vagina or even your colon and stuff like that, anything that we kind of get rid of the natural flora, which is a protective mechanism, will increase risk of having some pathogenic strains kind of overgrow. Previous UTIs and retrovesicular movement, so I added that in there. This is actually really important for the aspect of pyelonephritis because that will increase your risk of having recurrent UTIs, especially even complicated ones, because some of our organisms create biofilms, and we'll be discussing those in a little bit. So what are the different types of UTIs? So we have upper and we have lower UTIs. So the lower one, also known as cystitis, pretty much is inflammation due to an infection in the bladder. And that's the cyst, obviously, that's where cystitis comes from. And so the symptoms that this patient's going to be presenting with is frequency and urgency, burning, dysuria, so pain on urination, and suprapubic pain. Suprapubic pain is the nerve that innervates this area, and the top of the bladder is going to be your ilioinguinal nerve, and that kind of reminds you of a little bit of anatomy, bringing you back to those good old times. So just kind of integrating some of those things. Now, if this infection progresses and makes its way between the bladder and the junction of where your ureters enter, if it makes it in through that little sphincter, it can make it and travel up the ureter up into the kidneys, or into the calyces and then into the kidneys. And this type of infection is a little bit more complicated. This is what is known as a complicated UTI or an upper UTI. This is pyelonephritis, and it's pretty much you're going to have the same symptoms, obviously, because usually it's occurring in an ascending order from your bladder up through the ureters and then into the kidney. And so with that presentation, you're going to have cystitis plus fever and chills, nausea, vomiting, hypotension, and costovertebral angle pain. So it kind of makes sense that once the organism makes its way up right next to where all the blood is, well, there's not a lot of blood in the thick bladder wall and everything like that as it's stretching, so it's really not going to cause that much of a fever or chills or vomiting or even hypotension. It's not going to really cause any loss of fluid. It's just a simple infection in a sac. Now, if it makes its way up into the kidneys, it's right next to the blood because your kidneys are perfused by a ton of blood. And so inflammation obviously is going to be responding in that area very readily. And so at that point, inflammation leads to increase in your cytokines, and cytokines, gives you these fevers, chills, and all these other symptoms found here. In addition, once you're infecting your kidney, there's going to be some sense of pain or bradykinin release there, and that's going to lead to that costovertebral angle pain. They've changed the physical exam for this. It's no longer the CVA tenderness where you put your hand and then you kind of tap on the back. It's actually now where you just push in on the 12th rib, and that should elicit enough pain. So definitely be keeping a track on that when you go into your CPD labs and stuff. So now on to what are the main organisms that cause these types of infections. Now the most prevalent infection in everybody is caused from the organism UPEC, or uropathogenic E. coli. E. coli takes up the vast majority of urinary tract infections, and so I'm going to be talking about that quite a bit involving its pathogenesis. So remember your E. coli are non-encapsulated lactose fermenters. They're glucose fermenting, and then they're catalase positive. They are motile. This one in particular forms an IBC forming. This is an intracellular biofilm. We're going to be talking about that on the next slide. And so again, UPEC is the most common. So if you have a stem that goes through someone having a urinary tract infection, and they're not telling you anything like, this is actually an encapsulated organism, or it's making H2S, or it's a gram-positive cocci, if they're not giving you information to pick some other organism, and that means this question is basically asking you, what is the most common cause of urinary tract infections? If they don't give you any clues describing another organism, you go with EPEC. Which most commonly, because STEP kind of wants you to make sure, do you understand the basics of how urinary tract infections? Yeah, they could ask you a Proteus question, and they could ask you a Staph saprophyticus question. But if they just are putting a general question on, this person maybe is sexually active, or any of those risk factors I gave you on the last slide, and then they have a urinary tract infection, what is the most likely organism? Well, obviously, you're going to have to choose what is most common, that is UPEC. So be careful. There are some things, like I'm sure you've watched maybe some sketchy micro or something like that, and it's mentioned that Staph saprophyticus is your honeymoon cystitis and stuff like that, but it's not always the case. Staph saprophyticus is less common, far less common than UPEC. So if the question just says, they have honeymoon cystitis, what is it? Then it's UPEC. If they said, there's honeymoon cystitis, we do gram stain and it's gram-positive cocci, now you have Staph saprophyticus. So careful with your lab findings and stuff like that. In addition, if it's just general, then you're going for UPEC. That's your answer. Klebsiella is another organism that's encapsulated. Remember, your Klebsiellas are carbapenem resistant, and then these guys are lactose fermenters. These are usually more associated with complicated UTIs, patients that are on catheters or something like that. More like nosocomial infections that you're going to get Klebsiella from. Proteus vulgaris, this is another guy. He has a strange swarming motility. And he produces H2S production. So what is swarming motility pretty much is where you place the bacteria here, and then they kind of swarm and form these like ring-like structures. And this is actually what it looks like on the auger. So this is a kind of a swarming outward that makes this like target-like motility. And that's what it actually looks like on the auger. So if you see a picture of that, then that's your Proteus vulgaris. Remember, you got H2S production. So when you put this in a test tube, it turns black on glucose fermentation, and that's how it makes that guy. And then it is one of the few that is actually urease positive, so keep that in mind. This is one that it can actually break down some of the urea found within urine and make ammonia, and that alkali makes the urine alkaline. And when you have alkaline urine, a lot of the salts, magnesium, ammonium, and phosphate kind of can come together and form what is known as struvite. Struvite is a very large large stone. It almost looks like, I'm sure you might have heard staghorn caliculi, or stone that you might have heard in biochemistry or something like that. But this is another one that creates that, and it's known as struvite, and that's magnesium nitrate phosphate. And then lastly, it has this enzyme known as phenylalanine deaminase. I'm not sure how high yield that actually is, but it's the only organism you'll be discussing in micro that has that I know of. I'm sure there's other organisms that do, but this one they wanted to emphasize to you, so maybe keep a note on that one. All right, so now on to E. coli and how the pathogenesis of this occurs. Because it's the most common, it's the easiest to kind of describe how the pathogenesis occurs. So what happens first is you actually get contamination of the urethral area from UPEC. And UPEC is an E. coli, and you can just think, oh, where does E. coli come from? Well, it comes from, the colon. That's right. It comes from the colon. It comes from the rectum and the anus. You poop it out. And then what happens is, because females have a relatively close organ structure, this can actually increase its direction in the anterior position and make its way to become a contaminant in the periurethral area. So what happens once it colonizes, it makes its way into the urethra and then into the bladder. And how it kind of does this, it kind of binds on. And remember that we said E. coli is motile, so it has pili, adhesions, and then it also has the motility of its flagella to move along. So pili and adhesins help it kind of bind onto the epithelium. So it has two type of pili and adhesins. So there's this type 1 fimbriae. So this is something that is sensitive to mannose, meaning that it can't bind to anything that has mannose. So mannose is something you're going to find lining or on your cells, your epithelium, within your ureter and your kidneys. And so using just the type 1 fimbriae is going to do nothing for this UPEC. It won't be able to bind on there, and it will just get flushed out from the flowing urine. Where P. fimbriae is something that they use instead that is, it's not weakened from that mannose. So once it finds that mannose, it can actually bind and then make its way up through the ureter into the kidney, and that's why P. fimbriae can lead to pyelonephritis. So P and P. And then just the basics, it migrates in the bladder through that motility all around, kind of colonizes that. And within the bladder, actually, is where we see those IBCs, or intracellular biofilm communities. And this can cause some amount of inflammation, not really, but just enough of irritation to cause cystitis, right? And this biofilm formation that it actually forms once it's in these cells uses what is known as quorum sensing. Now, if you haven't had a science background or even a microbiology background, because it's more specific to microbiology, I'm sure this word kind of seems foreign to you. And it actually was mentioned in your cardiology lectures for micro, if you didn't notice. And that is actually what QS is for her cardiology that she was referring to. She just never mentioned what it was. She just said QS. And so obviously the teaching kind of lacked on those slides. So I want to emphasize what this is. And so quorum sensing is a way of communication. And what is that communication that bacteria have? So let's say we have one little bacteria here, and here's the surface. So here's the surface of epithelium, and this bacteria comes down here, and he kind of attaches and finds its way there. And he's like, oh, this environment's real great. Let me start proliferating. So he starts growing, and there's a whole bunch of these guys that start to grow, almost like a colony you would find on an auger. So we kind of grow all this guy, and he just continues like this. And now what they're like, oh, well, we're actually getting washed, so maybe the urine or whatever can kind of bump a couple off of here. And because this biofilm or whatever, this is not really biofilm, this is just a bunch of bacteria sitting on top of each other, actually can get washed away. And so what they end up doing is they want to stabilize themselves. And so they kind of secrete this matrix that holds them all together. I know this is a horrible picture, but it kind of holds them all together. And this is a biofilm, pretty much. A biofilm is just a way, it's almost like how platelets aggregate, there's binding to the endothelium, and then there's platelets, and then you aggregate more platelets and hook all these things via fibrinogen, and then you stabilize them as fibrin, and then you have a whole bunch of tons and tons and tons and tons of these platelets all just hooked to each other, right? So it's kind of this old meshwork of fibrin and fibrinogen and platelets. Well, here it's bacteria and these fibrous proteins that they kind of secrete out. And how do they tell each other, hey, it's time to secrete this protein, right? So here in the platelets, we had ADP receptors, which are aggregate to platelets receptors, and that leads to activation, and then that kind of leads to changing of your platelet surface molecules, allowing for binding and stuff like that. Well, here in the bacteria, pretty much what they tell each other is that once they're hooked to each other, they say, okay, let's secrete some more of this matrix and hold together as kind of a solid attachment section, and this is known as a biofilm. So how this actually gets communicated, how do the bacteria actually talk to each other, is they send out little signal molecules. So these little signal molecules get sent out, and this is actually what quorum sensing is the bacteria picks up these little things. They have little receptors. So here's the bacteria, and then here's another one next to it. And so this sends out our little molecules, and then this guy has a little receptor that lets it bind. When it binds this is called sensing, obviously, sensor like in neuro and everything like that. And so this is actually sensing of whatever this is. This is known as a quorum. A quorum is a little signaling molecule, and this other cell kind of senses it, this bacteria, and this says, okay, now I can activate and secrete out our little matrix, and we can kind of hold on to each other, okay? And that's exactly what quorum sensing is. That's pretty much all you should know, is that they communicate each other, they create that biofilm, and then E. coli actually does this inside of cells. This isn't on the surface necessarily. It can bind by its pili and adhesins and migrate around, but if it wants to stay within your epithelium cells and create its biofilm, that's what it does. It enters into the cells, creates this intracellular biofilm communities using quorum sensing. And this comes into play as far as the clinical aspect of UTIs. Why? Is because someone takes antibiotics because they have a UTI, it clears up, right? We've now removed all the bacteria on the surface because we've killed it with our antibiotics. So this person urinates it out. And then they do nothing different. All they're doing is just peeing. There's no sexual contact or anything like that. Suddenly another week goes by and they have another urinary tract infection. They did nothing. They even try to clean themselves extra or something like that, to the point of going, why does this person keep having recurrence? Why? It's because of these intracellular biofilm communities. So this is you have to be very careful with this. You have to watch out for these questions, and Dr. Rayner loves to test you on these. Understanding that E. coli lives intracellular. Therefore, it lives inside the epithelial layers. So if there were a question on recurrence and was asked, why is there recurrence? It's because intracellular biofilm communities, or because the E. coli cells are living inside of the epithelial cells, and they did not kind of slough off. They stayed there, and then were able to reactivate and form another infection. So these guys also can secrete some amount of toxins and proteases and kill the cells if need be, and then they ascend using the P. fimbriae. Once they colonize in the kidneys, they can make their way into the blood, and that can lead to bacteremia and all sorts of bad stuff. And so that's pretty much your pathogenesis for E. coli. So struvite stones formation, this is what I kind of talked about. And so we talked about how that urease cuts the ammonia, increases your pH, and that leads to precipitation of that struvite stone or struvite material, magnesium ammonium phosphate. And also this guy secretes out polysaccharide, and that allows for that crystal formation around it. So all those little, the magnesium ammonium phosphate actually binds onto the polysaccharide that it secretes. And that creates that struvite staghorn stone. And why they call it staghorn is because it creates the shape of the calyces, and calyces kind of look like horns if you were to fill those up. So that's why that is that way. So staph saprophyticus, this is a gram-positive cocci. It is catalase positive and coagulase negative. As we know, the coagulase positive is Staph aureus, and Staph aureus usually does not cause urinary tract infections. So this is usually happening in young sexually active females, but again, remember, E. coli is more common. If it's a general question, pick that. However, if it's saying you have a gram-positive cocci, then you got this guy right here. It is non-hemolytic unblood auger, and something that's very key. So we're going to be discussing some of our actual lab results that we can kind of pull out our urinary tract infections. Is this guy actually does not produce anything that will break up amino acids and form nitrates from them. And so this is actually one of the UTI infections that is going to be negative on nitrate. So keep an eye out for that. That's super high yield. Also, just basic lab tests, this guy is resistant to novobiocin. So here are the interpretation of urinalysis. So we have our normal ranges here, and then we have kind of the indicator for each of these results as an indicator of infection. So these guys are actually the two that you really want to be paying attention to. This is more of path questions right here, and then this one I could really care less. Because it kind of depends on the organism, right? So for leukocyte S rate, this is actually very positive in almost all of your urinary tract infections, and so this is kind of very specific to say this person most likely has a urinary tract infection. It comes along when you have pyuria and the presence of white blood cells, and that's where you kind of get this leukocyte esterase. Nitrates are positive in presence of most bacteria, but remember that Staph saprophyticus is negative for this guy. White blood cells, if you have an infection, obviously your white blood cells are going to respond, and so you're going to have that pyuria. So white blood cells are going to be greater than 10 per high-powered microscopy field. RBCs also can be present, epithelial cells sometimes, but not always that important as far as anything diagnostic, but it does provide that you have a good, at least a good sample. So pH from this, so the pH can be anywhere from 4.5 to 8, and this is usually can be elevated up to 8 in patients that have an infection with something that produces urea, so something that can break up that and form stones. So other infections of your pelvic area, we're going to kind of go into these now. So you have vaginitis in females, cervicitis in females, pelvic inflammatory disease in females, urethritis in both males and females, genital ulcers in obviously both, and prostatitis in males. And so kind of the main pathogens for vaginitis are usually kind of mixed bacteria. There are a few we're going to describe that are a little bit more important. Candida, so this is your fungal infections or yeast infections, as you might have heard, and then Trichomonas vaginalis, that's the protozoal infection. Cervicitis usually is something that's associated with trachomatis and gonorrhea. Same thing for urethritis in both males and females. And then pelvic inflammatory disease. It can be polymicrobial, but usually the questions that are involving this guy are going to be one of these guys. And you're going to need to cover in antibiotics for both of them. And that's just kind of a farm tie-in for you. So pelvic inflammatory disease, you're going to get this introduced to you in PATH if you haven't already. And pretty much this makes you more prone to ectopic pregnancies, scarring, all sorts of that stuff, especially in females. Because that can cause a lot of damage as far as the uterine cavity and the fallopian tubes and stuff like that. And it can cause adhesions and everything, leading to eggs being fertilized beyond that adhesion point, which leads to kind of constriction and ectopic pregnancy placement, in addition to not being able to be fertilized at all. And so infertility can come from this. So urethritis is another infection, just inflammation of that. Some infections that can additionally cause this are your Mycoplasma genitalium and Trichomonas vaginalis as well. Genital ulcers, we're going to be discussing those guys a little bit more in detail. And then prostatitis, usually gram-negative rods, but remember it can be gonorrhea and trachomatis. These guys are going to be kind of having a lot of gross discharge, and we'll be describing those. So let's talk about vaginitis. So polymicrobial bacterial vaginitis can be caused from a lot of different things, but it's usually what it is an endogenous bacterial overgrowth with an undergrowth of some of the lactobacillus. So lactobacillus is the bacteria found in your female's vaginal canal, and what it does is it breaks down the glycogen found inside your epithelial cells, uses that to create an acidic pH. And so this acidic pH kind of keeps out a lot of bacteria. However, if you have, for some reason, something that decreases lactobacillus in the vagina, that leads to an increased pH because we're not producing acid. And at that point, that lets a lot of other bacteria, anything endogenous on the skin or anything like that, to come and kind of overgrow in there. And things you kind of want to look for, as far as the stems, are clue cells or something like, oh, we see a lot of gram-negative rods found in here, and this person's having, vaginal irritation and everything like that. Now we're talking about vaginitis. So Hemophilus species, Bacteroides, which is a gram-negative anaerobe found within the lower GI tract, and then Gardnerella vaginalis is another bacteria that can cause this guy. And so clue cells are these guys over on the right, and we'll be describing that in just a second. So pathogenesis for this, pretty much mucin or cell-degrading enzymes. They have collagenase, sialidase, fibrinolysins, hemolysins. All these things kind of lead to these bacteria kind of to find their way around in the vagina and let them kind of overgrow. Other things are IgA protease. It reduces the host kind of immunity against them. In addition, these guys can have urease, which increases the pH more. In addition to it kills off some of the cells, so then these bacteria can kind of eat the nutrients from there. They do have amines, which also can increase the pH and let them grow further. So diagnostic are these actually two type of different tests. First one is your Nugent score. And so this is the wet mount, and pretty much you look for the gram stain, you're looking for gram-negative rods, and if you have over amount of gram-negative rods to gram-positive, which are your lactobacillus, then you're going to have a high Nugent score, and that suggests that this person has vaginitis. Oh yeah, keep in mind, lactobacillus are gram-positive rods. This is actually super high yield. I'm sorry I didn't write this, but lactobacillus are gram-positive rods. So they really like, do you understand what it looks like on Nugent score? That's how they write questions. Do you know? So I would read these Nugent score and the AMSL criteria very, very carefully, every piece of description. I would read those slides a couple times, because they have very in-depth, do you understand as a doctor? If you were that microbiologist, could you diagnose someone? Would you have that checklist to say, absolutely, this person has this? They want you to be someone that can diagnose based on the microscopy of this. So be very careful when it comes to those questions. These are some of the trickier ones that got a lot of people in our term. The next kind of test or criteria is known as the AMSL criteria, and this is pretty much if you hit 3 out of these next 4, you pretty much can diagnose bacterial vaginitis. So pH, simple pH test, if it's greater than 4.5, suggests something that's increasing pH, like we described up here. And then if you have a greater than 20% high-powered field of these clue cells, pretty much clue cells are epithelial cells that we scraped off, and they're covered in bacteria. And you can see all these bacteria kind of surrounding this epithelial cell. Also, there's a positive whiff test. So pretty much we take potassium hydroxide, or KOH. We take some of the discharge that this person has, put them together, and it makes this gross, fishy smelling odor. Sniff, sniff. And that is your whiff test. And then lastly, you can have that homogeneous, non-viscous, milky white discharge on actual physical exam, and that is one of the positives for this AMSL criteria. So usually it's malodorous, other than asymptomatic, other than the malodorous, fishy smell, sometimes discharge, can be itchy and stuff like that, but usually not too bad. So another guy is vulvovaginal candidiasis, and so this is actually a candida infection of your vulva and vagina in females. And I kind of put this little comic or this episode of Seinfeld up here. Jerry was dating this girl, and he didn't know what her name was, but she said, oh, when I was a kid, I used to be made fun of because my name rhymed with a female body part. And so him and his friend were kind of contemplating. He didn't know what her name was. He was dating her, but he didn't know what her name was. And so it was kind of comedic. Him and his friend were kind of trying to come up with what women's names kind of rhymed with different female body parts, and one of them that they thought of was mulva, or vulva was the thing that they were thinking of. It was pretty hilarious. So anyway, this candidiasis, this is something that can have pathogenesis involving adhesins, your ALS3. That's not super high yield, but I did emphasize it just in case they want to pick out something ridiculous for candida. There's also the directional hyphal growth. Contact sensing. It kind of senses its way around in the vagina in order to kind of grow upwards. There's dimorphism, or kind of trimorphism, really. But for these guys, remember those germ tubes, the pseudohyphae and stuff like that, and their budding yeast. That's something in that picture there you can see on the right. Biofilm formation also can come from candida, which is less common than the bacteria that can do this, but yeah. These guys also produce siderophore to uptake iron. It helps them grow. And symptoms pretty much are vulvar pruritus, or itching. There's this thick, white, curdy vaginal discharge. It's like cottage cheese, real chunky. And that's actually how they describe it. They usually don't use cottage cheese description that very much, but they could. They could give you that buzzword. Pretty much curdy or white or thick, chunky, something like that. Like, just think of the most gross thing ever, and that's probably what they're actually trying to get at there. And erythematous satellite lesions, because there's a lot of irritation of the vaginal canal and the vulva, that this can actually lead to those lesions there. Again, you do that KOH prep on microscopy, and that's allowing you to observe yeast with pseudohyphae and budding and germ tubes. But however, one thing they want you to keep in mind, that for candida, the pH is normal. It's not elevated like it was in bacterial vaginosis. So now on to our sexually transmitted diseases. So the first is Trichomonas vaginalis. And this guy is a protozoan parasite that infects the genital tract. It is actually the only sexually transmitted parasite that we know of. And it's a four flagellated undulated membrane trophozoite. And this is actually the only form that this guy has, is only trophozoites. There's no cyst or anything like that. It remains in this trophozoite or feeding phase. And it looks like this guy down here on the bottom. I almost think of it as like a little ball with a little guy standing. We're looking at the top of his head, and he's got a little sword, and he's trying to stick it out. He's trying to get out of here. So you see the little sword. He's like, let me out of this bubble. And that is Trichomonas vaginalis. It's a terrible way of looking at it, but now it's stuck, hopefully. So symptoms are frothy gray, yellow, green vaginal discharge. Gray, yellow, green vaginal discharge. It's very pruritic. Sometimes there's cervical petechiae, or strawberry cervix, and that's depicted up here. You can see that. And this also can infect the Skene's glands, and that can be very problematic for this patient because it's very painful. Diagnosis is modified Diamond's media, and so this is the gold standard for this. And there's an increase in pH similar to our bacterial vaginitis, as well as positive on the WIFT test. So you want to be looking for this guy as diagnostic. So that's what kind of differentiates from bacteria. All right, and now on to some of our other infections. Neisseria gonorrhea is our next guy. This is a gram-negative diplococci. It is intracellular. There's no capsule, and it's oxidase positive. Remember, gram-negative diplococci. It has type 4 pili, and remember, anything with pili is important when it comes to Rayner's questions. So this is something that these guys can change a little bit, allowing for evasion of the immune system. And so if there's recurrence of Neisseria gonorrhea, be looking for a pili as an answer there. That's super high yield. Also has IgA protease, as we discussed in respiratory infections, because Neisseria gonorrhea can cause upper respiratory tract infections, usually meningitis, but however, gonorrhea can cause that as well. And it's very similar to meningitis that has the same thing. Also has OPA, OPC, and porins. That allows for adhesion, invasion, iron uptake, and stuff like that. And then this one actually is very specific. I'm not sure if you actually were given this in any of your other lectures, but this is one of the only guys that has a lipo-oligosaccharide, LOS. It does not have lipopolysaccharide. This is a lipo-oligosaccharide. So there's no O antigen, and pretty much this triggers the same response as LPS, but again, this is LOS. So be looking out for that on stems, especially for CNS. He really likes that in CNS. So symptoms for males, it's white, yellow, green discharge. It's painful urination. Testicular swelling can occur if there's infection further down in the testicles. And then women, there's vaginal discharge, painful urination, painful intercourse, metorrhagia. And in the neonates, this can cause conjunctivitis, but it usually occurs within a couple days of birth and only lasts for about a week. Where chlamydia trachoma occurs about 5 or 6 days after birth and then progresses on for 2 to 3 weeks, enough that it can actually cause blindness, and that's your chlamydia. But here it's not so bad. So it also can cause dermatitis, endocarditis, meningitis, and then this guy is the complication of tenosynovitis. So please keep in mind that it can cause tenosynovitis. But also, I'm sure you've learned in Path with Neisseria gonorrhea that can cause Waterhouse-Friderichsen syndrome, where you cause clotting and blockage of blood to both your adrenal glands, and that is acute hypoandrogenemia. So diagnosis for this is that you use Thayer-Martin agar, which pretty much is chocolate agar plus some antibiotics that are selective for Neisseria gonorrhea. You can use it in CO2. That's not super high yield, but you can do gram stain for men, and that is actually diagnostic. You see gram-negative diplococci coming from discharge from a male's urethra that allows you to diagnose Neisseria gonorrhea. However, in females, it's actually part of the normal flora. And so at this point, you actually need to culture the Neisseria gonorrhea in order to diagnose it in a female. So keep that in mind. They really like these last two things. That's a nice, easy question. And hopefully you can get that point. All right, so now on to Chlamydia trachomatis. This is an intracellular bacteria. It is not gram stainable, so keep that in mind. They like that as well, that chlamydia is always non-gram stainable. It has these two forms known as your elementary bodies and your reticulate bodies. Remember that your elementary bodies are the ones that allow for infection or getting into the cell, and so they're the infectious form. And then they change into these reticulate forms, which undergo mitosis and they replicate and grow. And this is your mitotic or reticulate bodies. And then they convert back to in elementary bodies, and then they get kind of spit out to cause infection in the neighboring cells. And so that's the life cycle. That's super high yield for everything on chlamydia. And those aren't too difficult of questions. For males, penile discharge, same as gonorrhea, pretty much burning, urination, and usually sometimes itching at the tip of the penis. In females, there's abnormal discharge, dyspareunia, burning, urination, and then complications in females are a lot more prevalent and problematic, including endometritis, salpingitis, abscess, peritonitis. And then if it can make its way into the peritoneum, it can make its way up to the liver, causing Fitzhugh-Curtis syndrome or perihepatitis. Pretty much causes these adhesions of the liver to the surrounding peritoneum. It's got these like really stringy things. You could Google it. It's kind of gross looking. But in addition, it can cause reactive arthritis as well. This is known as Reiter syndrome, the reactive arthritis that comes up with gonorrhea as well. So keep that in mind when you get to your ICM courses in Term 5. Diagnosis, pretty much you have to collect the columnar or cuboidal epithelium. Why? Because these are intracellular organisms, and you actually have to stick a swab into the male's urethra, spin it around a little bit. I'm sure that's wonderful. I'm sure he's very happy to have you do that for him. And that allows you to gather a cell culture, and then that is the gold standard to diagnose. You can also do nucleic acid amplification tests, pretty much known as PCR. So a further disease that this can actually cause, the Chlamydia trachomatis, especially if it's strains L1, 2, or 3, please keep in mind L1, 2, and 3 strains are the only ones that cause this. This is known as lymphogranuloma venereum, or LGV. Pretty much what this is it causes an infection that makes its way up into the lymph nodes, and there's these painful buboes and some systemic symptoms that you have with this. And fever, malaise, nausea, and again, those lymph nodes, they're usually in the iliac region. I'm sorry, not iliac, but inguinal region, right under the inguinal ligament. And so there's like a swelling above and below, and it has this kind of indent because of the ligament above it. It's kind of weird looking. You can Google that. And then female, the lesion is at the site of infection, and then rectal infection can be caused from this as well. Pretty much collect epithelial cells, do some PCR, and you should be able to diagnose this pretty straightforward. So now on to some genital ulcers. So herpes simplex 2 virus, we talked about this before a little bit when we were discussing our skin infections, but now on to more of our type 2. So this is a lifelong chronic infection because these viruses remain dormant in the sacral root ganglion, which is your S2, 3, 4. Keeps the poop and urine off the floor, remember, so that's your sacral. So circular, it has a circular genome, and it usually remains latent as a transcript within those cells. It has neurovirulence, that's why it stays in the nerves, obviously, and then it can be reactivated with fever, menstruation, sunlight, and sometimes extreme stress. Usually the stress with herpes simplex virus is usually in the way of up in the face as like cold sores and stuff like that, but stress can also induce herpes simplex 2 down in genital. So this is genital herpes, just so I can give you the common name. So pathogenesis, it has glycoprotein-mediated binding to the keratinocytes and epithelial cells. It causes fusion of the cells. It has different genes that are produced, the different proteins that come from them, and then it causes severe cytolysis, and that's why it's so painful to these patients. And it's even painful before even the vesicle erupts and after the vesicle actually heals. And so this is something we need to treat our patients with analgesia like opioids and other things that have like neuropathic pain such as carbamazepine and stuff like that. Your tricyclic antidepressants can treat that pain as well. So morphology for this, your Cowdrey type A intranuclear inclusions. So that's your merging, molding, and I typed molding twice, marginization, and that allows us to kind of diagnose this, and that's a Cowdrey body. So syncytia, the cells, once they merge together, that is known as merging. Molding, pretty much what molding is actually molding is actually the nuclear formed kind of together, and then this actually should be marginization, where the nuclei kind of push all their condensed DNA out to the margin. So that is known as marginization, and that leads to that circular circumference. So all those 3 M's is what you're going to find on histology from that infection site. So primary, it's usually HSV2, but sometimes can be 1, and you're going to see those painful vesicular ulcerative lesions, fever, headache, malaise, itching, dysuria, especially dysuria that's super high yield, and then lymphadenopathy can also be found. HSV2, again, is more common. And then if you actually have an infection of this, an immunocompromised patient, HSV2, if they have genital herpes, actually can infect the meninges of your lower spinal cord and cause meningitis, but HSV1 up in the head can actually cause necrotizing encephalitis, and you'll get to that when you have CNS lectures. So diagnosis, zinc smear to see that those Cowdrey bodies, and then immunofluorescence or PCR can help diagnose. So Treponema pallidum is another infection. This is your syphilis, and we did discuss this in our skin lectures, and I brought a couple of those pictures in here so just to remind you and kind of keep it organized here. So this is spirochete. It does not gram stain. It's burrowing. It has burrowing motility, and it lacks a TCA cycle. That's why we can't really grow it on very good conventional augers. However, we can actually grow it in armadillo feet, which is super weird. This is a super strange organism, and it can grow in super strange animal feet, armadillo pads. I don't know why. Anyway, I don't know how they even found that, but anyways. So pathogenesis, it pretty much enters the minute lesions on the skin and mucosa membranes, and then it has surface attachment proteins that allow it to bind to what is known as fibronectin, which is found within your epithelial collagen and within your tissues. and that allows for pretty much the further invasion of this guy. And they really like that fibronectin. That's very high yield. The timeline is primary syphilis is 10 to 90 days, and that's going to show up as a chancre lesion. It is hard edges, has hard edges, it is painless, and then there's ulcerative thing. If I were to do a swab of this ulcer right here, it has some discharge, a little bit of moist discharge. I can swab that, put it on a slide, and then observe our under dark field and fluorescence treponemal antibody microscopy. I actually can observe these spirochetes on there. And that usually lasts up to 90 days. Secondary syphilis, that is about 14 to 30 days in length, and that is going to be your skin infection, which we have discussed before. That's that rash, it's centrifugal, including your palms and soles. Remember, only the CARs, Coxsackie A, Rocky Mountain spotted fever, and syphilis are the ones that involve your palms and soles. There are other things that lead to that, but as far as infectious forms, that's the one that leads to this. And then generalized lymphadenopathy, and then you can have condyloma lata, not acuminata. This is condyloma lata. And then alopecia can come from this. The skin infection is that copper-colored one, just a reminder. Tertiary syphilis is that the rash and everything goes away, but it usually involves more of the vital organs, like your heart. You'll have gummatous lesions, like in the face and your subcutaneous tissues. Aortic regurgitation in your heart can appear. Why? Because this guy actually goes and infects your arteries within your aorta, so the vasa vasorum, and so that's your kind of the blood supply to your arteries, and that this is known as endarteritis, and that can create that tree bark appearance, dilatation of your aorta, and that opens up your aortic valve, and that leads to aortic regurg. Neural syphilis is also a problem in here. This is known as tabes dorsalis, and so you're going to have that pupillary reaction. It's they react to light, or they accommodate. So there's a combination that occurs as far as the parasympathetics to your lens. However, they are non-reactive to light, and this is known as your tricky tricks, or your prostitute's pupil. And that is neurosyphilis. Also, tabes dorsalis includes ataxia and stuff like that. Why? Is because this remains in your dorsal root ganglion, and it attacks the myelin sheaths of your dorsal root nerves. And so you lose some sensory and proprioception and stuff like that, and that leads to ataxia. And so the latent form is also another form of this infection. Usually nothing occurs, and it can last up to about a year. For diagnosis, you can use a dark field and fluorescence treponemal antibody, like we discussed, a dark field microscopy. We can also use a venereal disease research laboratory, or VDRL, microscopic test. So pretty much we take cardiolipin, cholesterol lecithin antigen, and we put it under microscopy, and if this person has antibodies against that, then that would be a positive VDRL under microscopy. If we want to do it with cardiolipin bound to charcoal pieces, and we can actually observe it with our naked eye, this is known as an RPR. And both of these use this cardiolipin. Cardiolipin is a cholesterol lecithin antigen that we found and extracted from calf hearts, or cow hearts. So if left untreated, transmission, especially in females, can go to the fetus 4 years after primary infection. So that could be very problematic for one of our torch infections. So treatment of this is penicillin G, and it's very simple. You just give them one shot and you actually can cure them. So there's no reason for them to be able to come in and be cured of this illness. So now on our next organism, this is Hemophilus ducreyi. This is a gram-negative pleomorphic coccobacillus, aligned in chains. Remember, our H. influenza was our other Hemophilus. This one actually aligns in chains, so our H. influenza does not. Symptoms are pretty much ragged, soft, painful, soft chancroid lesion.
And I wanted to emphasize that soft apparently twice. I didn't even notice that. And this is very painful. And so because it's painful, you do cry. I do cry. Yeah, okay. And it has this cytolethal distending toxin and hemolysin. This is part of its pathogenic mechanism, and that is so high yield as to why I have it in bold and another color. They could just pretty much say, oh, this person has a painful soft chancroid lesion. And what is the pathogenesis? Cytolethal distending toxin and hemolysin. Don't miss that one. This is an easy point. So diagnostic is chocolate agar like our Hemophilus influenza had, but this is not Hemophilus influenza, so all we need is factor 10 or Hema 10, and that allows us to grow this guy. We can also grow it on gonococcal agar base, plus 2% bovine hemoglobin and 5% fetal calf serum, but that is less common. Another thing is Mueller-Hinton agar. We can actually grow this as long as we add a little bit of horse sheep blood. In order to actually diagnose it, we have to rule out everything that has similar lesions. So it has a chancroid-like lesion, similar to the chancre in syphilis. And so we have to rule out syphilis, and we pretty much do dark field microscopy for that. And then we also have to rule out, is this ulcer because of HSV, herpes simplex virus 2. And so we need to do PCR and make sure that that's negative for that guy. And that will allow us to diagnose Hemophilus ducreyi. Remember, it's painful, so you do cry. All right, one of our last few is Mycoplasma genitalium. So this is it has a triple layer external membrane, and it contains sterol or sort of like a cholesterol, like our cells. And so we can't target that with any of our normal antibiotics. We have to have something that targets that sterol and SID. And so in order for this actually to grow and diagnose it, we have to throw in cholesterol into the agar, or else it can't produce its sterol, and therefore it cannot grow. And it totally makes sense. These are usually free-living organisms. They don't have to rely on anybody necessarily, and they're self-replicating. What happens is they have this little tail over here that allows them to bind to our epithelium, and how it binds is this MGPA tip adhesins, and this tip allows it to attach on and then continue with its pathogenesis. So it evades the host defenses pretty much by binding to outer surface of cells, so it kind of hangs on, so our immune system kind of passes by and says, oh, I don't see anything, because it's usually attached on the outer surface, not on the inside. And then H2O2 and superoxides, this thing can produce, and that causes a lot of damage, inflammation, cytokines, all sorts of stuff that comes in response to this. But again, the immune system kind of can't really take care of it because we don't know where it is in specific. And then it can also cause that tissue damage. So Klebsiella granulomatous is another organism. It is gram-negative Enterobacteriaceae, similar to like E. coli and, well, pretty much all the other Klebsiellas. It's encapsulated. It can cause the disease known as granuloma inguinale. It has a safety pin appearance. I couldn't find any really good pictures of that, so I couldn't show you guys. But it is intracellular inclusions in macrophages, and these are known as Donovan bodies. And they are the symptoms from this disease: painless, expanding suppurative ulcer. So it's like this beefy red, and they tend to bleed real easy. I'm sure you can find some pictures of that. It's really gross. I didn't want to put them on here, so you can definitely kind of Google that real quick. But remember, they are painless, expanding. They have very pussy stuff, and they're beefy red because it bleeds really easily. Next is our human papillomavirus, and we're getting down to the nitty-gritty here with our last few infections. So the pathogenesis pretty much it infects the basal layers and causes growth and stimulation, and we'll be describing that in a second. It forms these prickle cells in the stratum spinosum, and those kind of increase in number, and that kind of can help us to kind of rule this in as one of our differentials. And then the skin can become thicker and hyperkeratosis. That's where you get kind of the wart aspect of this. And then the epithelial can form spikes, which even adds more to the wart-like aspect of this. And then the other things like non-melanoma skin cancers, basal cell carcinoma, squamous cell carcinoma can come from this infection. Also, laryngeal tumors can come from it, condyloma acuminata, which are external warts on perineum, anus, and penis. Remember, this is condyloma or condylomata.
acuminata, not lata. Lata is found in syphilis, and this is acuminata. So this is accumulating your papillomavirus. Virulence for this is so high yield. I just wanted to spend a little time kind of explaining what's happening here. So there's a bunch of virulence factors this guy has, but the big guys that are important are your E6 and E7 protein. So what happens in our normal cell cycle is we have our S phase before our mitosis and such like that. And we have G1, and then we go into S phase, which we duplicate our and grow our genetic material. And within this, we have certain checkpoints, and those checkpoints are monitored, and the DNA is checked from your P53 and RB. And if anything is wrong, we call this cell's mitochondria to release its cytochrome C, which leads to apoptosis of the cell. And so that's what our P53 and RB kind of come into play, as they're regulating gene replication and the replication of our genome. And so what happens is we actually, this virulence from this human papillomavirus, E6 and 7, come into play is this virus infects. It causes production of these E6 and E7 proteins, and those proteins find P53 and RB and stop them from working. So we're no longer checking our genetic material in case there's any mistakes. So what happens is, if there's keeps making mistakes, then those continue, and that can lead to cancers. And so usually this is only found in the high-risk strains like HPV 16, 18, 31, and 33, and those are the ones obviously that are going to lead to your cervical cancer, which is very, very, very common. So that's why this question involving this whole pathogenesis is very, 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 very high yield. You should definitely know that for path and micro. And then type 6 and 11 are Coniloma acuminata. Those are the strains that actually cause that one. Remember, not LATA, that's for syphilis. Vaccines, you have your bivalent type, which is your 16 and 18, quadrivalent, which is all four of these guys, and then enonovalent is these 4 plus 5 other strains, and that is known as Gardasil 9. And that pretty much sums everything up for the video. I hope you liked that. Don't forget to subscribe, and there will be some videos on multi-systems and HIV coming up pretty soon, hopefully this week. All right, happy studying.